Good evening, Kenya, and a warm welcome from the lakeside city of Kisumu. Oimore Udinade. This evening, we come to you live from Mama Grace Onyango Cultural and Social Center, a center named after one of Kenya's most formidable women and trailblazers. We continue a national conversation that touches every life across this country. It touches your life, your health, and your future. Since October 2024, when the Social Health Authority SHA was launched, headlines have been dominated by a lack of readiness, awareness, and policy. From border residents in Kondele to young mothers in Nyamasaria, the pulse on the ground is mixed. People are hungry for information. People want to know whether they can truly count on SHA. Online, the conversation is exploding. At Willow Health Media, SHA stories consistently rank among our most read, most commented, and most searched. The public is watching, but they're also worried, a fear of another broken system dressed in new clothes. Yet, amid this anxiety, there is hope. Hope that with the right reforms, voices from the ground, and accountability, Kenya can finally deliver healthcare that is accessible and transparent and, most importantly, fair. That's why we are here tonight, to listen, to ask the tough questions, and to bridge the gap between policy and the people. Joining us on the panel are leaders from government, the private sector, each with a stake in getting this right. Dr. Ogola Sunday is the Director of Medical Services in Kisumu County. He's a clinical expert and strategic health leader and a fellow in pediatrics nephrology. We also have Dorothy Mabunde, who's the founder of Don Amolo Memorial Kids Arc, DAMCA, an expert in public health research and implementation science, infectious disease, and community health. We also have from SHA, Hazel Koitaba, who is the Director of Beneficiary and Provider Management. She has been instrumental in the transition from the NHIF to SHA. And last but not least is Michael Adwera, who's the co-founder and CEO of Africa Inuka Hospital Group. He's a health management expert, passionate about patient-focused innovation and sustainable growth. Karibuni sana. This, for us, is more than a discussion. It is a moment of truth. My name is Dr. Mercy Korir, CEO and Editor-in-Chief at Willow Health Media, and your moderator for this evening. This is Willow Lifeline Dialogues Town Hall Conversation, and this evening, Kisumu leads the way. Please join us, whether you're here at the venue or online, to drive this conversation. Our hashtag is Let's Talk SHA. We are live on YouTube and our Facebook channels. So let's unpack SHA together and we go straight into the conversation. And my first question goes to Dr. Ogola, representing the county. Just to hear from Dr. Ogola, how is Kisumu doing in terms of SHA implementation?
Thank you so much, Dr. Korir, and the Willows Media in general. Kisumu, to go straight to the point, Kisumu is doing good in matters related to SHA. And why do I say so? SHA has two phases. Number one is the process of registration, which Kisumu is at around 46%. Kisumu population currently stands at around 1.2, and we've registered 580,000, around 46% as we speak. That is registration, because you know from the Act, SHA registration is mandatory. Number two, on the services that we are getting as Kisumu County, SHA has helped the county to improve on on its primary health care. So that means that SHA is doing well in Kisumu. Facilities which are level 2 and 3 currently are able to pay, to contract, and to expand on their services that they were not having before. On the last phase of SHA, that is the reimbursement. SHA is doing well in terms of reimbursement because almost every month there is some reimbursement being made. The fact that SHA is doing good does not mean that it doesn't have challenges. The challenges are still there. So generally, good. However, the challenges must be looked into so that we can improve it. Thank you.
Thank you, Dr. 46%, if going back to med school, that would have been a fail if the registration is at 46%. So it means there's a lot more work to do, and we'll get to hear from our audiences and the residents from Kisumu on where those challenges are. So next, I'll ask Dorothy, representing the community and who works directly with vulnerable children and people. From what you have seen over the last 7 months or so, how do you assess SHA in terms of meeting the needs of the community and the people that you work with?
Thank you very much. Just like you have said, I represent the community, so I consider myself a village girl helped by God to be sitting here with these distinguished panel members. For me, SHA, I would say from the community level, is not working, because I'm looking at that individual who goes to a facility, and even though they are registered by SHA, they still have to pay additional money to access the clinicians. So is SHA working for that individual? Definitely not. I represent the warrior community who are the sickle cell patients, and I have seen, previously we were able to register a number of households to NHIF, because then they would ease the burden from the program on paying medical bills. That is not the same now, because every time a sickler goes into the facility, they cannot access care. And even if for those that are registered, we still need to pay extra money for that, because SHA only pays for a blood for microscopy, malaria microscopy, which is something that the sickler will probably not be needing at that point. So for me, and from the community's point of view, and for the patients that I represent here, SHA for me is not working. There are certain life-saving therapies, like the RBC exchange, that is very critical for a warrior who has very frequent crisis. Currently only accessible in 2 facilities in the country, which is Nairobi West and MP SHA. And again, in those facilities, SHA does not work. So it means that that individual that I represent in the community that I support will not be able to access such services, because again, they are not available in the level 2 and 3 and even 4 facilities within the country. Okay. So for me, if the policymakers say it's working, in the boardroom it's working, but qua ground vitu ni different.
Thank you, Dorothy, for that feedback. And Hazel, I'll come to you last so that we get to hear feedback from the private sector, from Michael Adwera, from the hospital operations in your hospitals. What's your feedback on SHA? Is it working?
Thank you, Dr. Mercy. Good evening, everyone. Very good question in terms of is it working or not working? I think I would be lying if I use a summation, kind of like straightforward Boolean kind of response saying it's working or not working. Just as Dr. Ogola did imply, it's a journey. So from a private sector, we look at it in multiple components, in my view. So we look at it, for example, first, when it comes to accessibility. So what is our overriding objective when we really offer service? Is to provide access to quality and affordable healthcare. And to, as you know, in the private sector, specifically for our group, we are very premised on the fact that we need to ensure universal healthcare access, that lifts the community in which we operate. So to that extent, we take the first element, which is basically access. And when I rate the access, I would say, yes, SHA is working. And what would be my metrics for that? Very simple metrics we look at. For example, are we able to register people? Of course, we've come a long way. So I do not want to mix the transitional issues with current operational metrics. So I will leave the transition aside and the experiences of the transition and speak to the metrics with regards to what is the expectation when it comes to registration today. Does it happen? Yes, we are able to register clients when they walk into our facilities, and we are able to identify them, and we are able to provide service. So are we able to provide access to the care? Yes, we are able to provide. So to that extent, it works. The second element to it would be in terms of turnaround times. Because you see, a lot more often than not, perception is reality, because if somebody walks into our facility and waits for 2 hours, 3 hours, they would not care whether it's SHA working or it's the hospital that is slow. It is an overall experience that the client has. So for us, the turnaround times for approvals in SHA are amazing. I can say they're pretty good compared to other insurance providers. So you get the approval very quickly, and I'm very sure the members of the public that have gotten those kind of access get notification that it's been approved, you can be able to access the services. So to that extent, it also works. But you see in the private sector, there are elements that follows through. So I have registered, I have provided access, okay? The care has been given. Now there are subsequent processes that needs to follow. I think that's where now the elephant is in the room in terms of certain challenges that are experienced, probably that we'll talk into details. Whereas we are talking about, for example, if you run into problems, how would you get supported? Do you have that assurance that you'll get prompt support? Do you have adequate information to be able to deal with all the queries that you are going through in each and every day or from all the clientele? And then, of course, it's a last mile kind of situation. Once you provided care in a reimbursement model, how often do you get the reimbursement? And to what extent is the reimbursement? Is it in full or is it partially? Because remember, you have to run and keep the wheels running. Okay? And you therefore need to ensure that there's a constant flow of reimbursement to ensure service continuity. And I think those are the areas where now the challenges now start to crop in that we may need to look into to ensure that SHA works effectively as envisaged. So that's the opening remarks. Thank you.
Thank you, Michael, for that. And now, Hazel, you have heard from the county, the community, from the private sector. From your own assessment prior to hearing the feedback here, what were the residents from this region saying in terms of SHA either delivering for them in one way or another or not, and whether the feedback that you've had here is true?
Thank you, Dr. Korir, and good afternoon, everyone. I'd like to pick up from what Michael said, that every transition will have its challenges, and that's what we've experienced as SHA. We all know that the rollout process started on the 1st of October last year, and it's only been 7 months since we implemented SHA. And I believe when we look back at the journey and we look back at the challenges, as we've continued to improve our systems, SHA is actually working. And I'll give an example of Kisumu County. Kisumu County has about 255 facilities, and we're talking about government facilities, private facilities, faith-based facilities. And these facilities, and if I start with government, majority of the government facilities under the defunct NHIF were actually not getting any reimbursements under NHIF. But now, I believe Dr. Ogola can actually ascertain to the fact that all his facilities are actually getting reimbursed money for the services that they have been able to provide to Manainchi. and they are able to use that money to improve the services, which is what we are talking about, quality healthcare services. So when we look at what's happening in the government facilities, we're actually seeing that there's improved services, that people are able to access these services without having to move a longer distance than they should. We have continued to strengthen the primary health care, and doing this makes sure, again, that we are able to ensure that diseases do not end up becoming chronic when they could have been arrested in good time through regular checkups and being able to see a doctor when you need to in a timely manner. So I think with just that example, Dr. Korir, I could go on other examples on why we think SHA is working. Maybe I can add the issue of the referral system. Before, we were going to a level 5 to ensure that we get treated for a flu, and that actually in medical terms is a waste of resources. But now we're having enough resources at the lower level, the level 2s, the level 3s, level 4s, where you can be treated for those, what do they call them? Not the NCDs, but those regular diseases without having to waste too much resources in terms of human resource, even the cost of that care, and so on. So indeed, I think SHA is working.
So from a facility feedback and hospital feedback it is, but Dorothy was saying from that individual seeking care that it's not meeting the expectations.
Yes, thank you, Dr. Korir. I believe what Dorothy is referring to is some of these the NCDs, such as sickle cell. And we do have a lot of NCDs that we have been able to address in terms of how do we ensure that there's a benefit package that covers that. And I'll give an example of kidney disease or kidney failure. In the past, NHIF could not cover that, and there was a challenge because we could not go to the next stage of ensuring those who are getting dialysis actually are able to get the transplant, because that's actually the next step. So just like that, with sickle cell, there is a lot that has to go into place, and yes, we are possibly just reimbursing parts of the treatment, but to be able to fully do so, or to treat the disease fully, we need a few other things, like for instance, a registry. So we need a registry for those who have sickle cell so that we can see what is needed, the disease pattern, and also how much it will cost the care. So that's work in progress that I'm sure at the review of the next benefit package, this would be prioritized.
Thank you for that. Dr. Ogola, when you're making your opening remarks, you talked of challenges that are there with SHA. What are these challenges and gaps that you've experienced over the last 7 months?
Thank you. For sure, there are challenges, and you know, when a new thing comes, of course, it must come with some challenges. Number one is from transition. It was quite fast-turned. When NHIF stopped by 31st of September, on 1st of October, everyone was expected to have moved on a day to SHA platforms. And for that past 1 week, that system crashed, and no one could access the services. So number one was, with the SHA was the process of transition was, to me, was supposed to be a little bit gradual, so that you put your house in order, so that when we stop the other one, then this can seamlessly proceed. Number two, challenge that we get now for the people, SHA looks at services as equal. Most of the services are given and reimbursed at equality. Last year, that is 2020, 2 years ago, 2023, the Kenyan government passed 4 acts, which are now the laws. Number one was the primary health care. In this primary health care, a primary healthcare network was used in a model to improve on the primary healthcare services. And that primary healthcare services look into what we call, number one is promotive of health services. Then number two is preventive. Then it touches simply on curative and rehabilitation. Kidogo too, simply. So the main thing of primary healthcare is two, promotive and preventive. For us to strengthen that as financial model, then it means that the primary healthcare fund, which is one of the fund in SHIF, or the Social Health Insurance Fund, anchored in SHA, should therefore give in advance funds before you give the services. When you sit in a facility to give service and wait for reimbursement, you are doing curative. So, if we are talking of primary healthcare fund, which is preventive and promotive, but we are being reimbursed after giving services, there is no promotive, there is no preventive. We are doing curative. That means that ideally, primary healthcare fund should be given to facilities in prior before we start. So in July, when we are starting a new financial year, the money should come. So that we get more to preventive, use that financing to go out, to reach to these CHPs who are here, to do the promotive health appropriately. So that a facility X can go to the community using that funds to do what we call promotive and preventive. But once we are waiting for it, that after I've given the service, then you reimburse me, that is curative. So it doesn't give preventive and promotive a good face. Number three on the disadvantage is that SHA looks people equally. And it only helps the primary healthcare facilities. So it means that the service, someone X who pays this amount of money is equal to the services someone who doesn't pay in the primary healthcare fund, who is only registered, who goes to a level 2 dispensary and get the services. When you come to a level 4 and level 5, level 6, then the same money, the same service you are supposed to get is the same across board. It doesn't look into people with different eyes of how much you pay. So that is a disadvantage to the people or to the citizen. But advantage to the government, which is where I work. For the facility is advantage to me because it discourages you to go to private X, but to come to our facility for health services. Another disadvantage of SHA is the type of conditions that people have. Mwabunde has really expounded on it. SHA gives 500 shillings per year for outpatients. Critical patients, not critical patients, but patients with chronic condition, it is embedded in the act. You will see there is emergency, chronic and critical care services, if you read that act. But in the actual sense, SHA only reimburses 500 shillings for your outpatient. So if you have a condition like sickle cell, seeing a doctor, how much will that cost? Going for full hemogram, going for blood transfusion, it will not effectively cover. So that can be improved. So that if you are person X have such condition, then they can get these services. Another disadvantage comes now to the county services. That as a county, we are trying to strengthen our primary care network so that you don't get a much referral to the tertiary care. So that means that it is us who have really reduced giving you the better service you require. In primary health care, let's say for those who are in Kisumu, and we use Nyando, for those people who come to Nyando, your referral should be done to Aero. You should not come here to KCRH, Lumumba, or JTRH. Why should you come? You shouldn't come. So of course we still lack some speciality in some sub-counties that make you to be referred to the highest level of healthcare. That is our weakness, but we are working as a county government to improve so that you don't have much referral from those primary healthcare. If that is done, then you will find that SHA will be working, because now you will not be required to be paying for services like JTRH, because seeing you at JTRH, you will have to give some money, because that 500 is not enough for that facility. So SHA, the last challenge that we have is the transition, is that facilities that accrued more bills for NHIF should also be covered, reimbursed, so that they can clear their pending bills. Once a facility has a pending bill, it means that they will be stock out of drugs, they will be stock out of other things, because they have to pay pending bills before you procure new things. And that is audit query. You cannot pay for something and you are leaving a provider who provided you services or goods 2 years, 3 years to come. So there are challenges, yes. Those are some of the challenges that I can articulate right now, okay, but some also will come as we move forward. Thank you.
Okay. Thank you, Dr. Ogola. There's something you said that's an advantage to you and a disadvantage to the people coming to seek care in your facilities. And you said, because SHA pays similar between private and public, that it's an advantage because people will come to you, and a disadvantage to the patients. Is it not supposed to be a motivation for you as a public healthcare provider to improve your services and your quality of care to meet the standards of private healthcare? Because when you say it's at a disadvantage to the community here, then it means they are coming to substandard care, which should be something to worry about.
Thank you so much, Dr. Corin. In my opening statement, I said we are really trying to improve on our services. The services in the public service is getting improved because of the SHA reimbursement. What does that mean? As we speak, facility through the second act, which is called the FIF, Facility Improvement Financing, that was also enacted in 2013, gives the facility autonomy to use that money from SHA totally. And they are in a position to restock their drugs. There are still challenges of stock out, to expand on human resource. The government, if you look at WHO, we are still not somewhere near the number of doctors, the number of nurses required per a group of people living together. So each facility, as we speak, is having what you call contracted staff. So they can go ahead and do their contracts so that they improve the service. There is no way you can say the services are improved and people are queuing in line. First time is quality. The rest of the quality of services that we can talk about, the cleanliness and the rest, because it cuts across all system in health, is getting improved. And each county, and Kisumu is one, we have a dedicated quality improvement docket, subdivision, that look into each facility on the quality measures, what we are doing. The quality can never be 100%. It is something on improvement ladder. You cannot say you've reached the 100% quality. It's not there. There is nothing like that. It is something that you keep on scaling, doing something good day in, day out to improve on your average outcome. So we are doing a good job to improve our qualities.
Okay.
Thank you.
Thank you, Dr. Goland. I'll pick from the same vein and come to Michael. SHA reimbursement for any service provided is the same, whether you're public or private sector. what challenges, if any, are you facing with this kind of benefits tariffs? And is it sustainable to the private healthcare providers?
Thanks, Dr. Korir. Good question, and I want to just follow through from where Dr. Gola left with regards to reimbursement model. I think, if we are talking, for example, quality outcomes, then quality outcomes follows the ability to actually fund the process. And the whole, framework is actually based on we pre-finance and then we get reimbursed. And therefore, for private, it's actually very heavy investment. And like, for example, government, there's a bit of support in terms of payrolls, for staff. But for private, you are actually carrying or bearing the entire responsibility, right? From payrolls, consumables, supplies, everything. You pre-finance the entire service, and then you get reimbursed. So when we look at that and the situation, therefore, what's the challenge that we're currently facing? And one of the major challenge really in this aspect is not even talking about the tariffs. I'll come to that second, the current tariffs and benefits package. I think the key thing, which is, I would say, the big elephant in the room, is the historical debt. Yeah? So as a private sector, you are starting with a certain amount of a very heavy burden in terms of accrued debt under NHIF that has not really been paid off. And in addition to that, therefore, you will then add in any expenses that you're incurring for the provision of services under SHA. So whereas there is a very good progress being made by SHA in terms of the reimbursements of expenses or liabilities under SHA, if that reimbursement, one, is not 100% of what you've incurred as a liability at any given point in time, then it means that you are carrying over additional liability. And therefore, whatever additional liability you are carrying over, if you add that to whatever you've accrued in the past for years under NHIF, then for private sector is a very big and very heavy burden to carry. And that's why I would tell you for a fact, 70 to 80% of private sector, especially, it varies. The lower levels may find it easier to carry the burden, but as you go to level 4s and 5s etc., that burden is very high because they're actually providing specialized care, which is very expensive. Therefore, to have pre-financed it and to carry that liability over a very long period of time is completely very debilitating to actually the performance of these institutions. So it's a huge burden. So in reality, one of the opportunities that I think exists in ensuring the sustainability of SHA is unlocking this constraint by trying to see how best do we support the private sector by addressing these long-standing bills under NHIF. And remember, there's also transitional spend, which was for specific schemes, let's say civil servant scheme, that was done during the transition, and in addition to any dues that are actually sitting under SHA. Because you realize that if you're doing more specialized services, then you have more liability. So it's really, really key that if the private sector can be helped to unlock that area, then I think, by and large, that constraint will be addressed. Now, coming to the elements of benefits and tariffs, I think one thing that I must give it to SHA is that for a private investor, you'd want predictability. And one of the things that everybody cries about, even initially, which was a major concern under, let's say, NHIF previously, was that if a procedure is to cost 120,000 shillings, and we request for 120,000 shillings, what used to happen is that probably if I request this procedure in Kisumu, I may get 110,000. Then I move to Nakuru, I may probably get 150,000. But if probably I go to Nairobi, I may even get 180,000. So it was not consistent across. And one of the benefits I think that SHA has really brought on board is the consistency of that benefits, that tariff, across all the similar levels of facilities. So if I walk into a level 4 and it's for the same procedure, irrespective of the location within the country, I'll get a consistent, tariff for the same. I think that is key and that's beneficial. But the question is it sufficient to be able to offer that service? I think that's where the concern now starts to arise. And I do believe, there's a committee that has already been set up, which is for benefits and tariffs review advisory to the cabinet secretary. I think
If that committee delivers on its mandate and we look at these elements in terms of what is really the cost to serve for specific procedures, for specific services, and we address them based on the market rates, because it's about input and output. If you want a quality outcome, then we must look at the input into that particular service. And if we address that, I think we could come up with a standardized tariffs and benefits that are commensurate with the current environment in terms of the costs of service. And if we do that, it will go a long way, really, in improving the outcome. So I think there's an opportunity there.
Hazel, having heard Michael and Dr. Gola, how does SHA respond to the challenges? You've had some, and I'm sure you've had some of this before, to the healthcare providers. How do you respond to these challenges and their concerns so that you're able to address them in time? Because at the end of the day, they affect the people that seek healthcare in these facilities.
Thank you, Dr. Korir, for that question. I think the healthcare providers in this panel will confirm that we have continued to walk this journey with them. From 1st of October, we created WhatsApp groups. We even went further and divided the WhatsApp groups to categories so that we are dealing with public sector and their issues separately, dealing with the private sector and their issues separately, dealing with the faith-based hospitals, because we know faith-based most times give us their services for free, deal with their issues specifically and separately. We have a helpline and an email address where our healthcare providers can continue to pose their questions or get supported when they need some services rendered and they're not able to do so. Our staff are available 24 hours. I don't think anyone can say that they're stuck when they have issues and we are not able to deal in good time. Now, the issue of reimbursements, I want to address this in two levels. One, there's the pending bills for NHIF. Pending bills for NHIF are those bills that were incurred prior to 1st of October when we started the rollout of Social Health Authority. Naturally, with any government asset or liability, there is a process for reimbursement. And since then, there has been a committee that has been set up through National Treasury. The team was supposed to meet for 3 months, go through what is owed to the healthcare providers under NHIF and ensure that those bills are paid. So unfortunately, it will take a bit longer than was expected, but naturally, because of all that transition, there is a process. So that is being addressed. Then we look at what is owed currently, and I think if I had Michael right, there is the delay in reimbursement sometimes. But if we remember previously, when somebody needed to access services, they'd have to have what we're calling a pre-authorization. And sadly, it was a fact that you had to know somebody to call them and say, I'm in hospital. And sometimes this, the intervention needed is for emergencies. So you don't know how long you'll be waiting for that pre-auth. What has changed under SHA is that you go to the hospital and immediately there's an auto approval. That auto approval means that you get the intervention you need at that time, and then SHA will come in and now look at the bill. And that's why the delay is there, because now we have to go back and do a clinical review to ensure that whatever was being paid for, first, the service was provided, and secondly, that we are paying the right rate. So that has taken a bit of time in terms of reimbursements, because again, clinical reviews are done by experts. They have to be medics, who we haven't actually recruited as we speak today. But those are processes that are happening, and in a few months, we will not be having these delays. Since SHA came into place, 1st of October, we've paid out 35.5 billion to hospitals, about over 9,000 hospitals. That, when you compare to NHIF, was not the money that was reimbursed in a timely manner. We are actually paying back in 1 or 2 weeks. Before they would, actually the contract provision is that we should be reimbursing hospitals in 90 days. But the payments have consistently been paid in 2 weeks, maximum 4 weeks. So we're trying our best to ensure that we are giving the hospitals the money they need to provide the services in a timely manner. So there are all these good things happening. If I can just address Dr. Ogola's challenges, which again was to do with transition, but I also saw he was struggling a bit to look for those challenges because government facilities have actually benefited from SHA. 53% of what we reimburse actually goes to the government hospitals. The lower facilities are actually now getting their capitation in a timely manner. I know he said we should be paying in advance, but then that payment is actually pegged to the number of registered beneficiaries in the county. So that is how we calculate that reimbursement, and it's 900 a year per person. So it obviously, we have to see who accessed which hospital, how many people are registered under SHA in that county. Then we are able to reimburse the money, again, depending on the disease burden for the hospital. So that's a process, and that is why we have to do the payment in 30 days after.
But I can see he is nodding, so I'm guessing Dr. Gola is agreeing that the facilities at primary care level are being reimbursed. I hope, Dr. Gola, you are nodding in agreement. Okay, I want to open it up to the audience. Anyone with a question or a comment, please raise your hand up and we'll bring a microphone to you. If anyone has a question or a comment, please raise your hand, we'll bring a microphone to you. But before we come to the audience, I wanted to just ask Dorothy, you've had private sector, public sector, and SHA itself. How can these three different groups better engage with the community so that as a community, are able to articulate the challenges and the issues that you have so that they are able to be responded on time? And how can you help them probably improve the service delivery and the SHA?
Thank you very much. I think the community needs to see a trickle-down effect of the conversations that have gone on here when Dr. Ogolo declares very positively that he's seeing a positive effect from SHA, but we need to see that in the community. So again, I believe that SHA should make effort to reach out to the community to explain the rollout of SHA, because again, information is power, and lack of that again is the reason why we say it's not working. So it is important that SHA sends agents all over to explain why the things that we see happening in the community are happening. For instance, if I am a household that I have just repaired a house for with iron sheets, so they go out for registration of SHA, and they're asked, do you live in a house with an iron sheet? And of course they'll say yes. But who did the house? It's somebody else. Then I leave, I don't pay their bills. So again, there's a disconnect there that needs to be fixed. Otherwise, we are going to have these disparities and it becomes very difficult for the community to even understand why me in my condition where a donor has just built a house for me, I'm asked to pay, say, 1,000 shillings, and another individual next door is paying less than I am. So I think there is still something that needs to be done there, and maybe Hazel will help us understand why that is the way it is. Could there be people, again, out there, the SHA agents visiting households to assess and determine the actual rates that individual households have to pay? Thank you.
Okay. Thank you, Dorothy, for that. And I would be keen to hear from the community health providers here on the experiences on, registering people under SHA. So there's a hand up here. We'll get your question or comment.
Okay, I'm Dr. Silas Awor, clinical microbiologist. I work at JTRH. I'll stand with the community because most of my research, I do them within the community. I want to confirm and I'll support what my colleague Dorothy was saying, that SHA, in reality, to the community, it is not working. And I have an evidence. I'm such a person who speaks with evidence. A study which I published last month on demographic predictor of inpatient post-discharge stay in referral hospital in Kisumu County, Kenya. If you go to online, you are going to get my findings. My study was done at JTRH and KCRH. High percentage of our patients who has a post-discharge stay was due to lack of enough fund to clear the bill, even though SHA is there, but SHA is not taking all the bill. And it is well written. Right now, I'm doing a study with the Upstate University. We are doing a study on non-communicable diseases, on diabetic patients. Out of 50 participants, which we have enrolled since 1st of April, out of 50%, out of 50 patients which we have enrolled, 32 has got a post-discharge in this our hospital. The study is being done at KCRH and JTRH. And as we speak, this is one of 13-year-old who is supposed to undergo amputation due to diabetic, but the mother cannot raise the balance after the SHA has taken the cost. So, truth to be said, as Dori was saying, on the ground, things are not working. These things are just working in the office setup, but in the ground, they are not working. Therefore, a lot has to be done to enable this our community to enjoy what SHA entail. Secondly, or the last one, into our private hospital, they can't offer us the better service as at now because of SHA is not considering their disbursement after their treatment. So, as the same way you are doing the equally distribution, the 50-50, kindly you should also consider this private sector because most of them are the one which we have in our community and they are there to assist us. If you can support them, they will support us. Thank you.
Thank you. Thank you very much, Daktari, for your comments. Hazel will send that to you. We'll pick another question from that side, your name and where you come from and what you're representing. Then we'll come back this side.
Thank you. My name is Margaret Omondi. I work with a community-based organization called Women Concern Center. Women Concern Center advocates for rights of women and girls. And I am happy that the panel is here today because for a long time I've really wanted to be in a panel like this one to ask questions. Being somebody working with women, there's a lot that entails when it comes to issues of health for women and children at the community level. So my first question is a very simple one. We would really want to understand what is SHA and what is SHE. Is it SHE or what is it? Because it is a problem for the citizens of Kenya to understand these two things. Then, Dr. Gola, you talked about the percentage of the registrations that have been done in Kisumu County. I wish this would have been broken down for you to tell us, on this 46%, how many are people who are employed and how many are for Juakali. This would have made us understand whether your registration at the community is happening or we have a problem with it. Then, Daktari, you talked about the issue of payment, that we are covered 500 shillings a year, or I didn't hear it properly. 900. 500 per patient per year. Outpatient. Primary health care.
Yes, at a primary health care.
Okay, so I have a question on that. Na hii nitaongea na Kiswahili very simply. Ninalipa 500 per month. Then wewe unanipatia 500 ya kunisaidia the whole year. Does it make sense? Those are the questions that we have at the community. Because mimi kazi yangu ni ku make sure wamama wameregister so that they can get health for their families. amelipa hiyo 500 per month, that is 6,000 shillings. Then you end up, serikali inatupatia shilingi 500 ya huyu mama na familia yake. Daktari, it doesn't make sense at all. And then, we are talking about promotive and preventive. And I'm happy that umetuambia there was a problem at the beginning. Things were rushed. Kitu yenye nataka kusema, the promotive part of it was not done in the community. And this is why we are having all these challenges, because most of community members do not understand tulitoka NHIF tukiingia SHA kivipi. Hata kama mnatuambia tusirudi kwa sababu NHIF ilienda, we have queries that tunatakaga kuuliza. Some of the women that I work with, walilipa pesa yao the whole year. And at the end of it all, they could not get services because hiyo pesa ilikwama mahali. So I start asking myself, watu wanalipa, then you end up, you're not paying hospitals, ati pesa haikuja. So those are the questions that we have, and I think I just want clearance on this.
Thank you very much, Margaret, for your very good questions. Hazel will pick them. Let me come to the side.
Thank you very much. I'm called Kefa Ogui. I stand or I represent all the technical trainers in Kenya in a group called Kutuvet. And I will not say much, but only 3 issues. One, so many times people have called me all over the country that their requests are not being actualized very fast. And actually today, I happen to have gone to the office here to intervene for some 6 people who are saying their requests are still pending. And that's when I got the wind that there is a meeting here. And particularly when I heard Hazel is coming, a very senior person from SHA, I decided to come and attend and maybe express some reservation about what people are encountering. It is unfortunate because sometimes somebody is in a dire need to be attended to very fast, but you find that there were 5 cases today. So when I went there, I was told there will be a crucial meeting here, and I spared my time to come and attend and share with the senior people from SHA. And then there's an issue here that during the NHIF time, I was not getting information about people telling me that my cover is over, has been exploited. Right now, I've gotten so many people asking me, if I go to the hospital, I'm being told your cover is now over until next year. I don't know what could be done because there's outpatient and inpatient. But this one, I'm being told about outpatient, that they can no longer be treated because the cover stipulated, that the amount stipulated for them per year is already exploited. I started getting this from March. So I don't know whether during the transition, whether that amount was spent the other side or NHIF. So I want clarification. Otherwise, I can also say there were some advantages. When it started for civil servants, it has been very effective. It was effective and people are getting treatment very fast. But now some issues have started coming up. Thank you very much.
Thank you very much, Kefa. I'll pick one question from here, and then one here. We come to the panel. We'll still take the questions. We have time. So one more question from here.
Good evening.
Good evening to you.
My name is Ruth Owinyo. I work together with Margaret in a community-based organization. I have 3 questions. 1, I'm privileged to still have my parents alive and they are senior citizens. My mother was registered in one household. My mother was registered on her own and my father was registered on his own. So they are both paying SHA. Is there a way that we can merge these two payments so that these parents of mine can make one payment to SHA instead of two people in one household paying SHA? Number two, during NHIF time, my mother has high blood pressure. She used to walk to hospital, get seen by the doctor, and she used to collect her high blood pressure medication free. Today, my mother buys medicine every month for high blood pressure. So are we still saying SHA is working?
Thank you.
Thirdly,
You'd said
from the employer point of view,
Go
there
ahead.
is a time we pay NHI, we pay SHA through the employer. I made my payments through the bank. The check went through. It was paid to SHA. And I never received a receipt up to now. I have made follow-ups. There is no phone call, that there's nobody to call to ask questions. I do not want to talk to machines. I want to talk to a real person. Can SHA give us an office where we can refer our queries? Because I've written emails, just the way the instructions on that thing is. Write emails. I have written emails and I've not received any message up to now. Secondly, I have not received that receipt. It is still pending. My PRN status keeps on telling me that the payment has gone through, but the receipt it has not been processed. So how long does it take for you to process my check that has been cleared by 9th of every month, and yet I have not received a receipt? Thank you.
Thank you very much. We can answer those questions and then we come back to the audience. Hazel, most of the questions seems to be yours, starting with the very basic. What is the difference between SHA and SHIF?
Okay, thank you again, Dr. Korir. To explain the difference between Social Health Authority and the Social Health Insurance Fund, we have to see where this authority came from. So in 2023, His Excellency the President enacted into law an act called the Social Health Insurance Act of 2023. That act established the Social Health Authority, SHA. So that is who we are, the authority that replaced NHIF. When we look at SHIF, it's one of the three funds under SHA. So SHA now, unlike NHIF, actually manages three funds. NHIF, it was just the fund, that one NHIF. Here under SHA, we have the Primary Health Care Fund, which we have talked a lot about in terms of the level 2s, the level 3s, how do we access care there. Then we have the Social Health Insurance Fund. And that fund actually mirrors what NHIF used to be. If you remember, we had to make contributions into that fund, and then subsequently we could access care. However, now we are saying care under SHIF should actually be on a referral based, so that the lower level facilities, the level 2s and 3s, continues to treat those regular diseases, and then if there's any complications, then it moves up, you are moved up, you are referred to the higher levels. There's also a third fund, so SHA actually runs three funds. So the third one is the Emergency, Chronic and Critical Illness Fund. That fund is now the fund that kicks in if somebody has an accident and they have to go for an emergency care, that will pay for that service. If somebody needs ambulatory services, that fund will pay for that service. If you exhaust the funds that had been put aside for whatever critical illness you had, say cancer. Cancer, I think under our tariffs, was at 400,000 shillings. So once you exhaust that 400,000 shillings under SHIF, there's an extra 150,000 that you can continue to access under ECCIF, so that we can continue to treat that critical condition without you having to miss those services. So that is, I hope that is clear on what SHIF, the difference of SHIF and SHA. SHIF is one of the three funds under SHA. Mm-hmm. To go back to some of the questions that were raised, I'll start with Dr. Silas Owor. Yes, as from your research, it looks like there's a challenge with clearing bills. However, when I look at Joe TRH, and I go back to before October, the funding to that hospital was really low, at about 300 million or less. And now we've reached a 1.2 billion reimbursement in terms of reimbursement of funds, which is a huge leap in terms of what is coming back from NHIF. Yes, you'll have a few challenges when you say that some patients have not been paid for, but from what I know, because I work very closely with that hospital, some of these patients came in before registration. And we know that you have to register under SHA, and then to access care in a referral hospital, you actually have to make payments. So some patients came in, they hadn't done the registration, they hadn't made their payments to be able to benefit from the SHIF. And those are some of the challenges that are there. When I look at what was happening before devolution, even we leave the transition of SHA, it was worse. People used to be actually imprisoned in hospitals because they could not pay for care. At least now SHA is taking up to 90, 100%. For public hospitals, we are even saying it should be 100% reimbursement. Back to Margaret's question. Margaret wanted to know what percentage of registrations is actually Juakali sector. To be honest, we have had challenges with the informal sector actually registering. And what we have been encouraging the public to do is not only register, but register, undertake that means testing, and make that contribution so that when the time comes for you to go to hospital, you are able to access care in a timely manner. The formal sector is a bit advantaged in the sense that it's the employer who registers them. So, or rather, it's the employer who contributes for them. So automatically, they're already in our register. So our plea to the public and mostly to the county government, support us in ensuring that the public registers. And as we've heard from the previous discussion, registration equates the reimbursements in terms of capitation. So the more a county registers, the more money is actually designated to that county. So let us continue encouraging our neighbors, our relatives, our friends to register, do their means testing, which is a fair process to know how much you should pay, and also make that contribution. In terms of what we are reimbursing, it's actually the 900 shillings a year, not 500 shillings. And it doesn't work the way that it was explained. Because, for instance, even if we say 75 shillings is what you're entitled to as a resident per month, it doesn't mean that if you go to the hospital, they'll tell you that 75 will not treat your flu. It doesn't work like that because it's all collective, and you'll still be able to access services under outpatient without worrying what is in your pocket. It's just the figure 75 is what we use to allocate the money to the population in that county.
I want to come to Michael and picking on the question about still buying medicines, yet you have been covered under SHA and you go to a facility and you still need to be buying medicines. Is this also happening in the private facilities, or do you provide everything under SHA if somebody is fully paid up and up to date? And one of the questions from online, which will come to you and Dr. Ogola, is that that in public facility it seems not to work, but in private facility it's working. Is that the case? I'll come to you, then Dorothy, and then Dr. Ogola. Then we'll come back for more questions from the audience.
Okay, thanks, Dr. Korir. Good question. I think the question specifically talks about does SHA cover everything in terms of medication that you walk in and walk out, right? Yep. So that's the question. Mm-hmm. I think I will say this. This is why information is power. And I think this is where the opportunity for improvement for SHA comes in as really, really a good opportunity. Because it's that communication and clarity that will help people, they help the public to understand what can I get from what kind of facility, to what level of extent. So, for example, when Dr. Ogola was talking about, you have two levels of facilities. So you have your level 1, level 2, level 3, who are now covered under the primary care network, the PCN, right? And those are the ones we are saying that should be on a capitation model, but is more or less a reimbursement model. And in those ones, you are expected that you will walk in. This is not part of what you contribute or anybody contributes. This is what the government allocates for provision of primary health care, all right? So that's level 1, level 2, level 3. So if it's a private hospital that has now signed a contract with SHA for primary health care, and it's a level 1, level 2, level 3, therefore the expectation even in private is that you'll walk in and walk out, okay, with only SHA. That's the expectation, all right? Now, when you then move from that level of facility to level 4 facilities who are more specialized, and it's supposed to be more on a referral basis, and of course, there are certain level 4 facilities that have also signed a contract with SHA for direct access, so you definitely do not require any referral from level 1, level 2, level 3 to be able to access them. But when you walk into these facilities, the expectation is that SHA would cover, I'm talking about, for example, OP, the SHA would recover what you call, if let's say IP, SHA would cover a rebate, or the bed rebate, and you will then top up for the actual cost of accessing that service. So similarly, it's the same case if you walk, for example, into Aga Khan, if you walk into Avenue, if you walk into Africa Inuka, level 4. Because we have, within our group, we have different levels of facilities. So we have level 3 facilities. So in Kisumu, we have 2 sets of facilities. We have a facility in the middle of town, which is a level 3, and we have a facility in Milimani, which is a level 4. So if you go to the level 4 facility, the expectation is that you'll pay the full cost of the service. And that full cost of service means that SHA would then act as a rebate. So this is the clarity that is important to be provided to the community, to be able to know that if I'm in this kind of facility, this is the expectation. And therefore you have a choice to go to whichever level of the facilities that you want to access care on. Otherwise the confusion would be that if I walk to Aga Khan and I have SHA that is fully paid, can I get services and walk out? I think that would not be the right understanding. So there is an opportunity to improve that understanding. The other one was, sorry.
It seems to be working in private and not public facilities. Or is it the other way around?
I don't know whether it's the other way around, but I think SHA works in both facilities. Yeah, so whether you are in private, whether you are in public. I think the key thing is, what is the service that you are getting? What's the type of facilities that you have visited? And therefore, what is the contracted obligation, yeah, with that facility? And if that information is provided, and that is why when you come to private, I think one of the key things that all the private hospitals do is that they have customer care desks that clearly shows you what the packages, and the key thing about SHA is that these packages are available. So nobody will tell you that, you know, that's why I was saying at the onset, that what SHA really did, which was beneficial, was to standardize things. So if I walk into a facility, Africa Inuka, and it is supposed to be a CS, and we know it's 30,000, then it's not a question of, me telling you that Inuka you're covered 20,000, but if you go to Kisumu Specialist, it's going to be 30,000 covered by SHA. No, it's standard. It's covered 30,000 both ways. So therefore, if, for example, it's a level 4 facility and the total cost of the CS in that facility is 70,000, then you know this differential, you're going to pay for it either through cash or you are going to pay through it on a co-paid card. Maybe you have another insurance card. So it's very clear on what to expect. And I think that is what is key. Information, I think, for me, is very critical. The more we create awareness, the more we provide this information consistently and sustain that campaign, the more everybody will have the same common understanding, and it will actually reduce the perception that it works in private or it works in public and doesn't work in private. I think also another element I think may be coming up when somebody says that SHA seems to be working in private and not in public could also be quality of service, because there are other parameters that people are looking at. When you say it works for you, what does it really mean? Because it's not just access, it's also the quality outcome. So somebody may be looking at the fact that, yes, I've gone to the public facility, I have accessed the service, but unfortunately, it was not, the outcome was not positive, or vice versa. So it's also other parameters to be looked at. Access,
versus the outcome. So there's quite a number of things that needs to be looked at. Thank you.
Thank you very much, Michael. Dorothy, I'll give you a chance to comment on, the perception. And to me, it seems like there is information asymmetry, where there are people with information and then the community seems not to have adequate information. So I'll give you a chance to comment as we pick several questions from the audience. Just raise your hand up and we'll bring a microphone to you. There's a question up here at the front. And then that side, but Dorothy, you can go first.
Thank you very much, Daktari. I'd like one of the warriors to speak about their experiences, because sometimes it's good for us to hear some of these things from the people who have been impacted by some of the boardroom decisions that are made. So allow me to welcome Lindsay, who is a warrior, to tell us something about her experience with SHA. Thank you.
You can pick the microphone here, and then we'll come to Dr.
Hey, everyone.
Hi.
My name is Lindsay Berita, and today I stand here as a sickle cell warrior who has undergone a red blood cell procedure. Now, does SHA work? Honestly, if you ask me this question 2-3 years ago, I'd automatically say yes, it does. Because by then, all I required as a sickler was probably, if I have a crisis attack, I just go to the hospital, get 3-4 bottles of domosaline, and I'm out, I'm good to go. But here is a place where my condition has reached a situation where these medications no longer work. And I have to undergo a procedure. In this case, it is a red blood cell procedure, and it was started early this year, January. So the main reason we reached there is the attack became so much, ikafika point, sorry, I'm going to be a bit personal in this. I'm trying to rush as much as I can. Ikafika point, if the attack comes, then automatically you have to go into an ICU. Now, let me just long story short, we had to go through it, and listen, if this procedure was availed by the public facility, it could have been easier. But this is a procedure that is only availed in a private facility. So my condition is forcing me to go to a private facility that is, in this case, is Nairobi, right? So I reached there, they tell me that SHA cannot cover. I have to pay cash or have an insurance. My question is, I know SHA is growing, and I am hoping that either is it possible that these procedures be brought to a public facility to be accessible to the common mwananchi? Because not every sickler out there can afford 100, 150,000. And if that is not possible as per now, why can't we consider sicklers in SHIF, right? Because what SHIF says is, SHIF offers more comprehensive coverage, including outpatient services, preventive care, chronic disease management, and specialized treatment. So my question is, why was my procedure not supported? And if it can't be, and if by any case this procedure wasn't supported because I went to a private hospital, then why can't we support this? Why can't we bring this procedure to a public hospital and support this? If that can't work in the meantime, then why can't you consider sicklers under the chronic department? Listen, I end by saying this. I can't help my condition. It is nothing I can help with. But you can help me by facilitating the procedure that helps my condition.
Thank you. Thank you for your heartfelt.
As she says that, she's also paying for SHIF. And even with the SHIF, we were not able to access services for that procedure in a private hospital. So that is what I am talking about, and maybe Hazel would help us. And even though you mentioned earlier that sickle cell is not one of those conditions that are currently covered by the NCD SHA, but I think that it is important that we do that, because in this region, Nyanza and Western, sickle cell, the prevalence of sickle cell is so high that I'm sure in this audience, if I asked anybody who knows somebody or a relative who is a warrior, I think all these hands would be up. So when you talk about the kidney condition, I'm like, where is that prevalent? Could it be another part of Kenya? And what informs those decisions? Because if I ask Dr. Ogola here, how many people seek services for kidney ailments compared to sickle cell, then the ratio would indicate that maybe we need to consider sickle cell than kidney. So who makes these decisions? And is there something that can be done to help other people like Lindsay? Thank you.
Thank you, Dorothy. And I want us to specifically answer this. One, because we know, like Dorothy has said, Western and Nyanza, the prevalence of sickle cell disease is high. How come that some of this life-saving treatment is only available in Nairobi? I mean, it would only make sense for it to be available, say, in GTRH or somewhere within this region. So, Dr. Ogola, I would want you to answer or respond to what Dorothy and Lindsay just spoke about. Then we come to Hazel specifically on that, and then we take the other questions.
Thank you very much. And I feel our warrior, the situation that she underwent, she requested for a procedure, apheresis. Kisumu, as we speak, we have not equipped a facility that can manage apheresis and bone marrow transplant and the rest, the higher level. But it is in the pipeline. Victoria was opened last week, Victoria Annex, as a sickle cell and bone marrow transplant. There is need to do that, to equip it and to make it a standard where that procedure can be done. That means that as a government, we have a lot still to do. So that some services that are private, they should also be in public. But the question why renal, chronic kidney injury versus sickle cell, that please let the SHA answer. Because that is also a chronic condition.
Okay.
And for your information, most kidneys that we do dialysis are supposed to be adjunct to prepare you for kidney transplant. It's not a curative. It's just to keep you. And if we don't have a plan to do a renal transplant, there is no need for us to put more money on dialysis in adults. For pediatrics, kidney replacement therapy, hemodialysis or peritoneal dialysis is a curative because of most of them are caused by pre-renal cases. But in adults, most of them have what we call chronic kidney disease. So when we are doing dialysis in JOTRH or any other place, the administration and the leaders there should be making good progress to have kidney transplant, because that is the solution and not dialysis. Dialysis is temporal to keep you during that. So it is important to put that chronic, but later the SHA answer that. So it is a serious problem in Western, and Kisumu, we have a lot. Previously, the reason why we have not done much on it is this. At first, the settlers have packages from this management to this management to this management. Even in HIF, later, they could cover the hydroxyurea. At first, they were not even covering hydroxyurea, for your information. But due to advocacy that we are doing now, later NHIF could cover, even for the drug we call hydroxyurea. So right now, what we are doing is advocacy. And we believe, though I believe is not a strategy in science, we have the person here to tell us whether it is possible to improve and to include all that is required for settlers. Thank you.
Thanks, Hazel.
Thank you, Dr. Korir. First of all, to Lindsay, sorry for that journey you had to take to try and access that care. From what I've picked, there was something you mentioned about these procedures having to be undertaken in ICU. Actually, SHA does, reimburse for ICU up to 28,000, and that should cover whatever procedure was taken as an emergency at the time, which should include some of the interventions they made. So it would be very interesting to see why they were not able to enhance whatever SHA was reimbursing. But going forward, yes, indeed, sickle cell is one of the conditions that we should be prioritizing. I had mentioned earlier that it's very good that we start to collect the data, have our records in order so that now we know those real cases and how we can calculate the reimbursements. That is work in progress. That will be undertaken by the benefits review team, and we'll make sure that it's something that's prioritized as soon as possible.
Okay, thank you very much. So, thanks for that. We'll take a question here, and then we have somebody from the deaf community who will give the next opportunity.
Good evening. My name is Onyango Ndonga. I am a gynecologist in Kisumu. In fact, today I've met one person I met 7 years ago when they were 0 days old. I'm very happy. Secondly, I'm the chairman for KMPDU, the Doctors Union in Nyanza. And I have quite telling questions from this conversation that is happening today. To our director, who is my classmate in undergraduate, you know, when people tell you that SHA is not working, what they're giving you is direct feedback that at what level are we experiencing problems. And I think we should take it very positively, that we want a system that is working for us, that is responsive to our needs. Now, I have questions. An overarching question on sustainability. This question keeps coming up because technically what you are telling us is that we are not collecting enough to cover everyone. And then even more, you know, the devil is in the details. Even more telling, if you tell us 48% are registered, and you go on to Madam Hazel, and we go on and say that being registered does not assure you of certain levels of cover. It would make us want to ask, then who are the paid up members? Because we might find they are only 10%. Will 10% of paid up SHA members help cover the 55 million Kenyans that we want Social Health Authority to cover? I don't think so. We need about 80% of the people paid up for us to cover the whole population. Secondly, this is a question directly from my members who are doctors. They are asking, how did we cost the services that we are offering Kenyans? Because the Kenyan has paid for his or her services. But when they go to the hospital, some of the hospitals, they'll be told to top up something or have a second insurance to copay. How did we cost this procedure? I've just heard us say that 28,000 would have covered the ICU and the procedures thereof. I can tell you more solemnly, plasma apheresis will not even cost, a quarter of its cost is not 28,000 shillings. I can tell you that for sure. My other question now is to the government, Dr. Ogola. This facility improvement fund, is it retained at the facility, or are we compelling our facilities to send back this money into a centralized account by the counties so that they again borrow their money? Your son is given 50 bob by the uncle and you take it and you give them 10 shillings. You are not improving those facilities. I don't know, I'm asking because from my interaction with my members who are medical superintendents in some of those hospitals is that situation on the ground might be a bit
Okay.
Finally, is SHA going to be the vehicle to finance our healthcare? Or are we going to look into healthcare finance the way we have advocated for it for the past 50 years? And for the past 40 years, we've been advocating for the Abuja Declaration to be actualized. Are we changing our focus to make SHA be the vehicle for our health financing? Because what you're talking about right now is just part of healthcare. There's so much in healthcare that needs to be done, to be paid for, to make healthcare actualized. Thank you.
Thank you very much, Dr. Nyango. Let me pick a question from somebody from the deaf community. We'll get the translation from Meresha Witi.
I greet you all. My name is Bernard Mulama. I am a teacher at a senior school, what is it? Chief Onunga Senior School for the Deaf. Okay. I am from SHA County, but I live here in Kisumu. I really thank you for the invitation. My question, I have two areas of focus. I want to ask about these 5 million Kenyan people. I want to thank you, Dr. Ogola, for your explanation. You said that the quality of services in Kisumu are very good. Also, you explained that level 2 hospitals and level 4 and above, they almost have the same services. But my concern is one. When you see in Ahero sub-county, when you are transferred to Kisumu for treatment, what will make them transfer you to Kisumu for treatment? Like there was a deaf person. We have an interpreter at Jaramogi Oginga Odinga, but it is only just one interpreter. So if a deaf person is sick in Ahero, and this person gets some communication barrier and decides to come to Jorot, he has come because of accessibility. Because he can only access it at Jaramogi because of the interpreter is there and not in Ahero. And he cannot be transferred just because of interpretation. Yes, you have said there are challenges, and especially in transition. I have accepted that. But how many of our disability persons access this? Let me go back now to community health. You community health supporters here. When you meet deaf people in the community, how do you communicate with them? Ogola, do you have any plans for that, for them? We want to see more accessibility in care. I felt about my sister who was sick, who shared her experience. I have a son with the same condition like the lady there. We have really suffered. Sometimes back, they text me to go to SHA. They wanted 24,000. Where do I get this from? There's not even money for registration. So you people really need to look into this. Sometimes you include people and you leave other people. Please try to include everybody. Thank you.
Thank you. There's one more person. Marisha, you can just sign again. So we give them that opportunity.
Thank you so much for this opportunity you have given to me. I want to introduce myself. My name is David Ongoro. I have disability, and I'm also a health person. I advocate for the health issues of the persons with disability. The panel has talked very well, and I appreciate you for that. I have worked in the area for health for almost 15 years now, in different areas. And I think I have some experiences in this. So, I have issues. When it comes to health issues, many people living with disability, they have a lot of challenges, especially in SHA. In Kenyatta Hospital, in the Kenyan Constitution, Article 43, Caption 2 and 1, says that every Kenyan has a right for access of health standard, very good standards of health services. That is in the Constitution. And we all voted for this Constitution. But when it comes to health, people with disability and have challenges, they must pay for SHA. I have disability already. Sometimes, maybe I have a challenge in money, finances. I don't have a job. Some disabled people also they have multiple disabilities. Yes, they have multiple disabilities. So these people, they need urgent services. But they are not able to get these services because they have not even paid for that SHA. This is a very big challenge. And again, when you see this person, like the county government of Kisumu now, and other counties, we appreciate them. They are making baby steps. They are making some steps inclusive of persons with disability. They employ them. They have employed interpreters in health sector, and that is a congratulations to you. But same, I strongly recommend that if it is possible, we really look at the PWDs, especially in the village. The ones who have graduated, please let us give them employment. I have graduated, like me, I am a graduate. Why must you employ an interpreter? You can also employ me. PWDs come first. Then the interpreter comes second. But many times, it is about the interpreter, and PW is forgotten. Now I have a question to the SHA team. How many PWs do you have there? Persons with disability, how many do you have employed in SHA? How many deaf people do you have in SHA employed? That's a challenge. You have a challenge in getting data. Because PWs don't have any information about SHA. If you ever ask a deaf person, what is SHA? The deaf person will ask you back, what is SHA? So I don't know. I don't know. Ask others. They think SHA is for others and not them. So, what I'm suggesting, we go deep into the village, in health issues, not only where we talk, then we don't implement. Many times, we have such like meetings, meeting after meetings. Is it possible after talking, then we implement what we have talked about? That's a big challenge if you're not going to implement. Thank you.
Thank you very much. We'll take those questions and then quickly we'll look for closing remarks. Let me start with Hazel. How many people with disability are employed with SHA? And the other issues that they've raised about inclusivity and them not being in a position to pay, yet they're expected to pay. And on that vein of payment, an online question came in from a student where they're saying they're a student, they're unemployed, and they're required to pay 1,031 monthly to enjoy the benefits of SHIF. I guess that's after doing the means testing. Why is this the case? So this is really a question about people not being able to pay, being required to pay, otherwise they're locked out of accessing healthcare as enshrined in the Constitution. Hazel, and then we'll come to Dr. Ogola.
Thank you, Dr. Korir. In regard to employment at SHA, SHA is actually an equal opportunity employer. We ensure that people are actually onboarded to SHA, not because of who they are, but actually because of the skills they have. So in regard to the number of PWDs we have, I don't have the exact number here, but we can check. But I know that we do have a few people. In regard to, I think I'll combine David and Bernard's questions, where we're talking about accessibility to services, especially when they need an interpreter. With that, I think, Dr. Ogola, you may be able to expound in terms of what the county is doing to ensure that, that we are able to provide services for people living with disabilities. Also, what I've heard is that the challenge is paying these contributions for most people who live with disabilities. And I wanted to bring to the attention of everyone here that the State Department of Social Protection actually normally has a kitty where they're able to pay for social health insurance for people living with disabilities, the elderly, and also vulnerable children or orphaned children. So there's that amount which is available. They do have, they have their officers at the ground level, and I'm sure that list is always updated it's updated regularly. But again, in partnership with the county, it would be good to know what the county list is, and that list can be given to the State Department of Social Protection for inclusion in terms of paying for insurance for people living with disabilities. There was a question of the student who's paying 1,031. Normally, if the payment that, or rather the premium you get after undertaking your means testing is more than what you can afford, there is an appeals platform within the whole the system where you can appeal that amount, stating your case. But I'd like to mention that as a student, you should actually ideally still be covered under your parents' household, so you shouldn't even be paying that extra amount separately. So that is allowed to the age of 24, or if you have proof that you're actually in school. So if you'd like, we can review that again through our branch office. I think I'd introduced Philip, and you can stand again so that if there's any further questions, we can have those handled. From my end, I think that covers that. Thank you.
Thank you. Dr. Gola, your responses on people living with disability.
Thank you. The county is doing a lot on matters to do with disability. One, we have a division, disability mainstreaming. You realize that disability mainstreaming was not neglected but had not gone so much to the public. Right now it's very robust. We are registering, and myself, as I speak here, I'm the last person to sign as a director when you have been assessed so that you get registered. And it is now, after that, it is online, you register, then you start enjoying what people with disability are given, especially the taxes are reduced, everything that goes with it. I know it is not 100%, but that will be improved as much as the complaints are coming in. Kisumu, we have only 2 people who are in health who have been trained to interpret. That is very less, and I hear him, they have to travel from Ahero to Kisumu, JTRH, because of that access for translation. When counties, especially for Kisumu, when we advertise for posts, it is written down, those with disability are encouraged to apply. So the only way you can get employment is that you apply. However, for those people who are already in the job market, it is the duty or it is our responsibility to take them for studies, to sponsor them. And as I speak, there is no one in health that has applied and Kisumu County has failed to give them what we call scholarship. So for such trainings. It is, for those who are there is no much people applying to go for translation, but I believe it's because they are going to have 2 duties, but the payment is still 1. So ideally, if you are in service, like let's say a nurse, and then you go and give another service of translation, ideally, there should be some allowances, because health workers is not for translation. That has not been effected. Maybe that is the reason why more people are not applying. But as I speak, there is no one who has applied to go to study, and we've rejected to give scholarship for translation. However, we encourage you every time that we advertise. It is written in the advertisement, those with disability are encouraged to apply so that they get the opportunity to help. In fact, it will be very good that you give the service, health services, and also you help us in translation. It will be a wonderful thing. And I encourage you next time when we advertise, please apply and come to the offices.
Okay, thank you. Thank you, Dr. Gola. I'll take 2 really, really burning comments. Dr. Ria has had his hand up here, and the lady at the back and the gentleman. Okay, 3.
Yes, good evening.
Good evening.
I barely hear myself. Okay, mine will be very short. I think first, this is just a challenge to the director, Hazel Luis here. I think some of the questions being asked, it is just a signal that maybe your customer care is not handling stuff, because some of them are personal in nature. Maybe you can take that up so that it can be sorted by officers on the ground. And then on the issue, to follow up what my chairman here is talking about. My name is Collins Omolo. I'm a Kenyan. On the issue of SHA not working, it's an issue really of perspective. Because like you've heard our story, SHA is definitely not working for her. Director here might be happy because our facility are getting much more money, same to Inuka. So it's actually an issue of perspective. You know, it's like those debates were from opening some other law court in Compare with the CJ, and somebody cracked a joke. When we're doing those debates in primary school, a witch doctor is better than a thief. So you just pick a side and no one is wrong, yeah? And no one is right, or such kind of thing. My question really is, and this is a challenge to you, Mercy, and maybe our media team, and this part, actually an issue I've been championing myself in my personal capacity, on the issue of transparency and accountability. And I think my chairman here raised it, because on whether SHA is working or not, that is not an issue, but we want to know on sustainability, how much is SHA collecting? If the director here said herself that he doesn't know how many people from formal sector have been enrolled, how many people from informal sector have been enrolled, how many are paying. But from a presentation I saw in 30th April, out of the 4.6 million people in the informal sector who had done the means testing, only 0.5 million were active. They were actually paying every month. So if SHA is working and SHA is a good thing, why is only 10% of people who voluntarily can choose to pay are not paying? Almost 90% are not paying. So that is something that we need to pick. How much are you collecting? And then the issue of claims. You know, we like making political statements. 45,000 to 50,000 people are registering daily. But really, how much money is getting in? And in facility, I would have liked director here for Inuka and even director here from the county, how much value of our claims are being paid. You know, SHA can say we have paid 35 billion, but maybe the whole facility is 100 billion. It doesn't make sense. So how much of those claims are they actually paying? And then lastly, on the issue of pre-authorization, I think, Director, you talked about it when you're beginning, that the system had been automated. So you automate, and actually that's a challenge that I would have hoped the Director for Inuka here will have talked about it. A surgery, for example, in October, the system then was automated. So you apply for pre-authorization, the system says yes. But now when it comes to payment, you've heard Director say that the people who are supposed to do the review have not even been recruited. So facilities have not been paid, close to 7-8 months. Yet you're saying that SHA is what?
Working.
Let me stop there. Back to you. Thank you, Marcy.
Thank you, Collins. We'll take the question.
Okay, thank you. My name is Titus. I've been in this field of health systems for a number of years, and more specifically in healthcare financing. I've been listening, and I've listened to our leaders in this country speak. There is a problem which might not be solved here. Number one, rethinking healthcare for 55 million Kenyans. Very good. How much will it cost to rethink for those 55 million Kenyans to provide healthcare? Do we know as a country? The answer is no. Even if you ask His Excellency the President, he will guess figures. So number one, we need to cost our healthcare. Because when you listen to these people, I'm a professional. And you know, I don't like just making statements so that we pass time. I always like making statements so that we can change this country. So, Daktari, thank you, Dr. Korir, for giving me this opportunity. Number one, we don't know the cost of care in Kenya. So we might not even quantify what we require. And if you told me, I've been a director of health planning and budgeting. When you ask me where I come from or where I came from, I can specifically to 1 shilling tell you the cost of healthcare. But have we done that in this country? When you compare NHIF and SHA, to me, actually I was doing analysis of NHIF, that system. I could put data and analyze what I want and come up with results. So what I can tell you, which you need to think about, look at, was NHIF the problem? Or is it the people who are the problem? Or is that interest is the problem? So that we solve these things once and for all. Because from where I sit, Kenyans are suffering. Honestly, they are suffering. The last time I went to hospital, I took my daughter, was yesterday at night, to a pediatrician. So I don't want to divulge more. So Kenyans are suffering. The next one, let us look at, after looking at the cost of care, let us look at how to equip our facilities. We talk about consumables, we talk about, in fact, to me, I'm not bothered about infrastructure. if we have consumables and quality healthcare. That's the most important thing. This mortar, stone and mortar, doesn't make sense. If we have theaters, we have equipments, we have consumables, we are good to go, and we have professionals. Because right now, doctors, nurses are languishing around here, and yet we have not employed enough staff. So what are we talking about? So my contribution is on policy, which I said might not be answered here.
Okay.
So the last one, Daktari, we have FIF. I like it. Facility Improvement Financing. At first we did Facility Improvement Fund, and we realized that it was not coming. Then we changed it to financing. When you look at its implementation, is it implemented? Maybe in Kisumu, not other places. But why was it? Because we looked at PFM Act, that's where we derived it from. When counties could not come up with their own FIF because of personal and unnecessary interests. So its implementation. Nobody is talking about implementation of FIF. And now it is making us to be in an awkward situation. So please, let us ensure we follow the issues of FIF implementation. And finally, the tariffs. I personally participated in public participation on the tariffs. And I even came to the auditorium in Nairobi because I'm a professional. But the things we were telling you guys, you looked aside. So I was wondering, did we just come there to take per diem, to take tea? So those are the same things. I remember I raised the issue of sickle cell because that is my friend. We work together. And you know it was not included. So let us look at these tariffs. The people who sit and make decisions for us at the ministry and at NHIF do not have the picture on the ground. They make for personal interest or because they are coerced to make them, and then they are protecting their jobs. Thank you.
Thank you. Thank you very much, Titus. I want to give the gentleman there, he's been very patient, next to Nuru. He has actually been here with us since midday. So let me give him the opportunity to say something. And our CHP will come next, and then we'll close there.
I'm called Tadayo Mubara. I'm a Human Rights Western Kenya Human Rights Network member. And also New Hope Disability, that is my organization. And Opinion Shapers. I have a suggestion. For us PWDs, I'm a PWD, that's why I'm not standing now. I request that if SHA can cover our working aids, like me now, if you cater for my working aid costing 20,000, for me to come back to you, it will be 7 years. So I think even for visually impaired, they should also cover that working aid. Because that is the challenge which we have. We PWD, if I can get working aid, then my things will be just okay. Another thing also, we also have institutions for PWDs, like Nyabondo, Boys Where I Land. It has that workshop is the best in East and Central Africa. One day if it is there, Daktari, one day visit there, you will see it. But for it to work efficiently, if the SHA covers our working aid, then that is the institution which will be mandated to do the services. You understand? I thank SHA. Unlike NHIF, where somebody was just coming to claim 500 million and the institution is not there. Yeah, January here, in Nairobi, he was demanding almost 500 million, but when they went there physically to see the institution is not even there. Records indicate it treated everybody. But you see with the SHA, now, I hope that you strengthen and you ensure that the health institutions which have credentials are the ones allowed to give those services. Okay. You understand? Then, my last comment. It is very sad if doctors are lamenting here. I hope in your, I'm not a, but I hope that in your institutions, there is a way of challenging your grievances. You know, when I go to hospital as a patient, if I have a grievance and I tell a doctor, his work is to say, you should have a mechanism where you can challenge what? But you don't come and lament in the public. It seems even your institutions, you don't believe in them. You are the people who are making your institution not to work. You understand? So I have a much we blame SHA, which is not even true because I'm a member of the community. Let us be sincere and realistic in whatever we say. For this insurance to work, let us pull our efforts together. The last one, which I also want to request. The previous one, NHIF, I used to pay it, but not monthly. What I used to do, if you can access my past records, you will see. What I used to do, anytime I get money, I used just to go and deposit there. So you could find that 3 months are paid for the whole year. But when this insurance health authority program came, I already paid 3,000 extra. But my request is, can it be reflected there?
Okay.
Thank you very much.
Thank you, Abaya. Let me take from the community health promoters. I know we are under pressure to have many questions asked. Please make it brief if we are to give an opportunity to other colleagues.
I'm called Susan Owili, a community health promoter from Manyata Bay. I only have 2 recommendations or maybe suggestions to the SHA authorities. The first one is that our working station is always in the households. We always visit the households, we know the way they are, the way they are staying. So at the place for means testing, I'm suggesting that at least from the place for income, can you please start with 0 to 5,000, because it is 0 to 10,000. Whereas, as we visit these households, we see these mamas, we find somebody is just chomaring mahindi. This person cannot be from 0 to 10. Then, another place also, maybe you'll ask that, is that house yours? Maybe the husband died, and it's the husband who built the house. And maybe she never gave back to any child. This woman is suffering maybe in a bungalow. And when you do the means testing, it will give her, maybe she pays 1,000 or even more. So at least in that area, I want you to at least try and make some changes, because we see them, we visit the households, and we know what they are feeling. My second one is that as we visit the households, there are some families, like when maybe they're all employed. It has happened to many of us, and they ask us questions. You register a father with the dependents, then you are again told to register the wife, then again with the dependents. And these are even people who have other insurances. So my request is that maybe if you can merge these things, so that if one person is registered on SHA, all should be under that person. Then for this forum, I must say that we are very grateful. At least we have gotten some questions, some answers, which we are going to take back to the community. Thank you.
Thank you very much. Suzanne?
Thank you. So
please make it brief.
Yes, thank you, Dr. Mercy. And the panelists, I'm Caleb Odhiambodanga. I'm coming from the Opinion Shapers, the civil society group in Kisumu. I have maybe 3 quick concerns. The first concern, as you can see in the entire members who came in, if we are to vote today, we have to say SHA is not working. That is us from the public opinion. It is very clear that what our mother Dorothy was saying, we can go by that. And that one put me to post 3 recommendations. One, we all understand how SHA was brought in, because it was purely the president's agenda to transform the health sector. And the president was so much on it that could not listen to anybody. Our president was so much in this SHA that he could not listen to anybody. And he was able and ready to do anything to make SHA go through. It's very pathetic if you hear doctors as also complaining like the patients. And that is the truth of the position. So my request is, can we recall back that document policy for a public review? Can it be called back for a public review so that Kenyans can willingly give back what they feel about SHA?
Okay.
2, under the issue of transition, because there are gaps in transitions and other areas, I will request Dr. Ogola, the director, kindly, health is a very sensitive matter to people. And really, I'm shocked to hear from your explanation. Because one, you are a director. And it's like you are playing a PR to us. You are like almost playing a PR. Kindly, get down to listen to what people are saying. These are your people. You are there to serve them. Don't play a PR to their lives because they are suffering. What they are telling you is what is on the ground. Listen, accept, and where this gap, kindly find ways of adjustment. Because the truth of the matter is, Michael Hospital is performing better than your hospitals in Kisumu. In your hospitals, you find even the pressure, the pressure machine is not working. The battery for the pressure machine is not working. And to make it worse, the county government's budget is calling for 45% of the entire county budget. That is around 100 million getting into the health sector. Then you want to tell us that SHA has been giving you money that now you have been doing better. Where is the county government money going to?
Okay.
Kindly listen to what the members are saying so that when you go back to the boardroom, adjust. Don't reiterate what they are saying. Pick points and go back to the boardroom. The last point is, I'm asking for at least the rates should be clear. Because if Madam is saying they are paying 900, you are saying we are paying 500. Who is now telling us the truth? You are saying 500 annually. Madam is saying 900 annually. And both of you are senior people that we expect answers from. Who is telling us the truth? Please, please, I beseech you, because we see better, we privatize the healthcare.
Thank you, Caleb.
It's better we declare, just a minute, I'm finishing. It's better we declare Inuka to be our hospital than this hospital you are telling us, because you are just playing with that PR. Thank you.
Thank you very much, Caleb, for your honest recommendations and questions. And then the very last one, please make it less than a minute.
Thank you so much for this opportunity. My name is Florence Nyawara. I am a mother of a child living with autism and epilepsy. And for me, SHA is not working for me because this is a child who needs therapy at least twice a week. With epilepsy, this is a child who uses this drug daily. And when I go to a public health facility, you get that the drugs are not there. For me to be able to take my child for therapy, I need to pay. SHA is not covering for therapy. And if I go to these other private hospitals, they need another health insurance apart from SHA. Yet I make my monthly payment. I am very timely with my payment. So if I told SHA was working, why should I pay for therapy? And it's not something that I chose my child to have. It's a disability that this child has. So it's a real concern. I'm talking of a person who is from the village who cannot afford, because before the child that is done for the therapy, you need to pay at least 200 to get a receipt. So I'm imagining a person who is from the village who is not able to raise these 200. What becomes of this child? Thank you so much.
Thank you very much, Florence, for that. And what I'm picking is there's a group of Kenyans that SHA hasn't properly addressed: people with disability, people with special diseases, sickle cell, for example, the deaf community. And Hazel, let me start with you, picking from where Florence left, and then I'll cue you on the other questions that were raised.
Thank you, Dr. Mercy. Florence, on the issue of physiotherapy, there is still a review on what can be offered under that. As you've heard, there's a panel that has just been gazetted, I think, hardly a month ago, and part of their work is to review the benefits, the tariffs, and see what may have been left out and what needs to be included. So those are things that we look into, and I'm sure by the time we review the benefits, it will be part of the additions.
The questions by Susan on really the means testing. Can the means testing be relooked at, or is that work under progress?
Yes, thank you, and thank you, Susan, for that input. And I also want to take this opportunity to thank the community health promoters for the work you do in partnering with us to register Kenyans. The assisted registration has actually helped us greatly in improving the number of registrations around the country. So we are very grateful about that. I have taken into consideration that bracket to be reduced from 0 to 5,000 as opposed to 0 to 10,000. Indeed, situations are different. You'll go to the ground, somebody may look like they have a stone house, but when you look at the income, it's not going to match what they're living in. So those are things that are being reviewed. Actually, there has been a review that has been ongoing to change the algorithm so that the means testing gives us a better assessment than what it has in the past. But I will pick up those two suggestions.
I talked about walking aids for people with disability and also visually impaired. Is this something that SHA can consider, especially because we know there are facilities and organizations that can do this for a much more affordable price?
Yes, thank you, Dr. Mercy. Indeed, with the review, some of these aids will be reviewed. We started off with the current package, being able to provide hearing aids. I'm sure with the next review, we will look into other aids that are needed for those people living with disabilities.
Okay. Then Collins asked, how much is collected by SHA vis-a-vis how much is paid out? Because you may be collecting 100 and paying out 10.
Thank you for that question. As we'd earlier mentioned, SHA was rolled out on the 1st of October. And as at end of April, we had collected close to 40 billion or thereabouts, which is actually an improvement from what we were collecting under the NHIF. As you heard before, I talked about payments being at 35 billion so far. So we are still collecting a bit more, but our appeal to the public is please let us take the next step after registration, do our means testing or means assessment, and proceed to pay our premiums, because it's those premiums we use to pay back to the hospitals and ensure that those who need care are able to get that care in a timely manner. Thank you.
Thank you very much. And on that note, let me ask Adrera to check if what is paid out, because he was asking about your claims ratio. What you claim versus what you paid, is it commensurate with what Hazel is talking about? Because that should be about 87, 88% payout.
Yeah, thanks, Dr. Mercy. I think this point I covered it at the onset, because I said this is really the big elephant in the room. And the composition of what is the liability is the issue here. So you find you have the outpatient, you have the inpatient, and you have the surgicals. And what Hazel was actually indicating to us that for outpatient and inpatient benefits, I think reimbursement goes to close to 80 to 100%, bearing maybe a smaller shortfall. So basically, if you have a scenario whereby, let's say your liability is 10 shillings, out of the 10 shillings, you have 7 shillings, which is actually surgical, and you have 3 shillings, which is basically OP, outpatient and inpatient, chances are you'll get 2 shillings out of the 3 shillings being paid. So which means, if we only look at those two parameters, inpatient, outpatient, we look like you're being paid 90% all the time. Your reimbursement is up to date. But the challenge, the key challenge is the costly part of that care, which is the surgicals. And that's where we have a bit of delays that needs to be unlocked for really the private sector to work. Because the major part and the most expensive part of that service provision is on surgicals. And that is where there's delay. And that's why the doc was saying that, the pre-authorization is very quick. You offer the service, but I think there is a challenge which Hazel was actually alluding to the fact that some actions is being taken in terms of resourcing that particular area better to ensure that that review process of the surgical happens faster, and therefore the reimbursement become more, fast enough and consistent. Okay. That would really help unlock that area.
Okay. And since you're on the mic, I'll give you the chance to give your closing remarks.
Okay. So thank you, Doc. So I think this is one, I think thanks to the fellow panelists, for this evening participation, but more so also to the entire audience. I mean, we have really the community from Kisumu, and we thank you very much. I mean, from the private sector. This is really a partnership. It's not, to us, it's not a business. This is a calling. I mean, you can't be in healthcare if your sole intention is to really make some money. I think you will be probably in the wrong business, because there's a lot that goes into service provision. It's a very, very demanding exercise. And we thank you very much for trusting us with the opportunity to serve. So when it comes to the key things, I think the key thing and the key objective of SHA is the universal healthcare goal. And if we have to get to that extent of providing universal healthcare in the country, I think there's, we make the transition. We are already on the journey. I think you can't stop the vehicle and then start saying, let me fix and throw out the engine and throw out this and that and that. What should be the emphasis and the focus should be continuous improvement. We should be better today than we were yesterday. And therefore, my recommendations comes from that aspect. I would implore to SHA to look at the feedback that is coming through. And those feedbacks are in various elements. One, in terms of the processes, I think we all kind of agree in terms of registration part of it, access part of it, working beautifully. I think there's challenges with regards to the system, and those challenges needs to be addressed in terms of stability, in terms of consistency, because that really affects the customer experience. Then there's elements that we need to look at, which is basically all aspects of reimbursement. It's key, because remember the entire supply chain, and I like the fact that Dr. Gola was saying that they're getting a good amount of money, and I would wish the private sector to also get the same amount of money so that we actually unlock the chain and be able to provide care, because that is key. So the other thing that is key for the sustainability of SHA going forward, because it's about sustainability. We can do well today, and if we don't really address the pertinent aspects that will ensure sustainability, we may not be able to go far. Okay. And one of it is actually the informal sector. If we can address the fact that out of the 4.6 that actually we say have gone through the means testing, it should not be 4.6. So 4.6 million needs to translate into 18.5 million of the people that have registered, that 100% of these people really go through means testing. And then if we can then ensure that out of the people who have done means testing, also 100% of them become active users by actually making contribution of the premiums, then we'll have gone a long way. And the key to that is please provide accessibility to information, address the challenges that are coming in, get the feedback, and we work as partners, both the government, both the public and the authority, plus the whole government, to ensure that we can be able to deliver the universal healthcare agenda.
Thank you. Thank you very much, Michael. Let me go to, thank you, audience. Let me go to Dr. Ogola. As you give your closing remarks, you address the questions asked by Collins about customer care really being one thing, because people have a lot of feedback that seems to be failing and not reaching the ears that it should, and the issue of availability of consumables and the issues of FIF.
Thank you very much, Dr. Korir. One, I'll push it back to Dr. Collins. Yeah,
Okay.
that's, but there's FIF, because I don't want to be a politician the way they think. I'm not a politician, I'm a scientist, my friend. If I say something from where I sit, let him answer if this is, if FIF is not 100% in Kisumu County.
You're putting...
It has been like a political arena where people say yes or no from him.
Is FIF in Kisumu County?
Thank you, Director. You know, I've been put on the spot by my boss. But actually, like Director said, Kisumu was actually one of the counties. You know, there was a Kisumu FIF Act long before even the national passed the FIF Act. So Kisumu FIF Act is active, and actually 100% of the facilities, they get their money.
Thank you. So that question of FIF implementation in Kisumu is 100%. There's no money from facility. That facility that comes to the county CRF account, none. We still give some money from CRF to the facilities. So that is answered, that FIF is not substituting money to facilities. It is to augment. If you read it, my friend, you will get the first statement, FIF is to augment, meaning the money from county should still go to facilities. So the money you are saying that county is having, that we are still sending facilities money.
Okay.
Are we together? Good. The next question.
Your closing remarks now.
No, I have a lot of questions that I have to answer, because someone is going to political. I'm a scientist, my friend. I'm not a politician, and I'm not running for any position.
No.
So when I say FIF is working, I made statement on the advantages. And I came again and made the challenges. And I made a statement overall that from this SHA is working, because the advantages outweighed the disadvantages, my friend. Are you getting what I'm trying to say? So if it is not working, the reason why we are here is to hear the challenges or the problem why it is not working. One of us who is a secular said why she's saying it is not working. Another question there we get, why it is not working. It is not a public political statement that SHA is not working. It is not working. Why? And that is why we are here, so that we can improve what is not working. But I tell you, the advantages of SHA outweighs the disadvantages of SHA. That's the reason why my statement was, SHA is working.
Okay.
So in my parting shots, him is in private sector. Private is to make profit. You cannot compare a public facility to a private facility. If you compare a Hero to Inoka, you will be out of your mind. It's not science. Are you getting what I'm trying to say? So when you are speaking, please listen and be scientific. Do not speak politics. Speak science in such a forum. Because you are comparing that, we allow you to go to Inoka because it has better services. But you will have to pay more. SHA will not cover everything at Inoka. They will tell you, please cover this and this. But in the public sector, where I stand, SHA is supposed to cover you. If you've paid for shift, you are supposed to be covered fully. And that means that the quality of service you expect at Inuka, cutting across from bed, the type of how many nurses, how many doctors, must be high than the public sector. So if you want to compare that we go to private or public, we expect you to go to private because the services are better. But I tell you, we love to pay more. So the parting shot for me is that SHA, no, before the parting shot, you talk about recalling it. It is an act. It is in law. Before law in pass in Kenya, my friend, there's what you call public participation. So even the SHA, there was public participation, my friend. So if you didn't give your views by then, what you can do is to start the process of getting a new law. Get the signatures, what, you go and read that, so that we can change another law, which is not SHA. As at now, it is an act. It is in law. So the process of law in Kenya, there is a way of how you can bring another law or disown this one and bring something. That is what can be done. But we cannot say the president to recall it. The public participation was done, everything was done. So it is there to stay. My parting shot, therefore, I urge all people in Kisumu County to register for SHA. Our registration is still less, and from the registration, the rebates, which is primary health care fund, comes to this primary health care network according to the number of people who are registered. And healthcare financing is one of the major pillars of health system. For us to provide health, the service we expect, we must have one of the pillars called financing. However, for us to achieve UHC, the SHA is just in one pillar, which is called financing. We have to support all the pillars of health system. Okay. Human resource, equipment, drugs and products, all of it, so that we talk of universal health coverage. Thank you.
Thank you very much, Dr. Ogola. I'll give Dorothy chance for closing remarks. Hopefully they're not as long as Dr. Ogola's. Very briefly.
Thank you very much. I would like to tone down from Daktari's sentiments and his closing remarks. And for me, because I represent the community, I would just urge SHA that it needs to be very intentional and objective in its implementation of the process in the community. It must put people first, above everything else. And we want to see tangible changes, because the stuff that are spoken in the boardroom, the decisions that are made, are not felt in the ground. So that is where the problem is. We want to see tangible changes in the implementation of SHA. Otherwise, SHA will be considered as the fire that fueled the death of healthcare in Kenya. Thank you.
Thank you, Dorothy, for those very concise closing remarks. Hazel, your closing remarks, very briefly.
Okay, thank you, Dr. Mercy, and to the audience, thank you very much for giving us this opportunity as SHA to listen to your feedback. I'd like to let you know that we've taken every comment as positive criticism for us. We are still trying to improve our services, and we're sure with whatever has been discussed today, you'll start to see improvements in the next few weeks to come. I think for me, I would say that let's look at it holistically, not as SHA, but is this country actually attaining universal health coverage? And for me, I think we have started that journey as a country, and we have actually accelerated that journey since last year. And I'll tell you why. I've been in health for 10 years, started at the county level, and we started at a point where people used to sell land. They used to sell their animals to be able to pay for healthcare. when we look at what was happening 10 years ago and what is happening now, I think you can all have a testimony to tell about how that has transformed. We've come from a place where health services at the county level at the start of devolution was very poor because all the monies received at the county level were going to the county revenue fund. We are now at a point where we have the FIF, where now we are able to ring fence money for health and ensure that it goes back to improving healthcare. So I think it's good we look at it holistically. SHA is only one arm, a health financing arm, but we still need support from health, in terms of health, human resources, in terms of health products and technologies, and so on. So it is a collective effort, and I am confident that in the next few years, Kenya will be one of the first countries to actually attain UHC, actually in the continent. And to close, I again request and appeal that we continue to register all Kenyans. Tell your neighbor, tell your friends, tell your siblings that we have to register so that we can all benefit from this fund. So not only registering, make sure that we do our means testing and make our contributions, because that is the kitty we use to pay the hospitals. Thank you.
Thank you. Thank you very much. Hazel, let's give our panelists a round of applause for our conversation and for giving the information. And as Susan said, they've gotten some of the answers they've been looking for. My parting shot to Dr. Ogola, though, is that the challenge, I think, that is coming from the people is for you to improve the quality of care, even if it means the beds, the staffing, so that you can match Inuka and give him a run for his money, so that people don't have to choose between Inuka and, the county hospitals, and they're only coming to the county hospitals because they don't have additional money to pay. So I think that will be my parting shot to you, Dr. Ogola. And the people of Kisumu, Erokamano, thank you very much for hosting us, and that brings us to the close of tonight's Willow Lifeline Dialogues Town Hall, right here in the beating heart of Kisumu. From insightful truths to tough questions, some from you, the audiences, both live here and online, what we've witnessed tonight is the power of public voice meeting policy. And you've seen that they've been taking notes and taking note of what you have been able to share with them. SHA is more than a system, it is a promise. But as we've heard, that promise must be backed by clarity, fairness, and above all, trust. Whether you came seeking answers, raising concerns, or simply trying to understand how SHA fits into your life, we thank you. As Willow, we thank you. Because transformation doesn't just begin in the government offices or the boardrooms. It starts in forums like this with voices like yours. To our expert panel, thank you very much for your candor and for your commitment. To everyone who has joined us in person and online, please let's keep the conversation going. Our hashtag is Let's Talk SHA. We'd like to hear more from you as we keep this conversation on. Challenge your leaders, demand better, because healthcare is not a privilege, it is a right, and it's enshrined in our Constitution. We'll be back this Thursday, the 15th of May, from the City of Champions, Eldoret Town, for yet another town hall dialogue on SHA, where we are trying to reimagine healthcare for all the 55 million Kenyans. If you missed any part of today's session, you can catch the full recording on our Willow Health Media's YouTube and Facebook pages. But this conversation for us doesn't end here. Let's keep the dialogue going. Let's share with us your thoughts, tag us and join our online Willow Health community, and follow us on all our social media platforms. Subscribe to our YouTube channel for exclusive interviews on health and much more. This has been Willow Lifeline Dialogues, the Kisumu edition. And until next time, stay informed, stay empowered, and stay healthy. I've been your host, Dr. Mercy Korir. Good night, Kisumu. Good night, Kenya.